Carpal tunnel syndrome, symptoms, diagnosis, and treatment from Parkway Neuroscience and Spine Institute, part 1 of 3.
I really enjoy the topic of carpal tunnel syndrome because it's, on one level it's relatively simple. It's a very straightforward thing, but the more you get into it, it's a little bit more complicated, and you have to be very careful. How many people in here have been treated for carpal tunnel in the past? Raise those mangled hands. Show me the scars. There you go. The woman on the left, she looks way too happy to be wearing that gigantic splint, so I thought that was kind of funny. So anybody who has carpal tunnel and has worn that has known that it's not as pleasant as she makes it seem. This is our facility on Western Maryland Parkway. Hopefully you'll get to see it in person sometime. On the right side is where there's a new gigantic building being put up right next to it so that we can have additional services there with more therapy and orthopedics and imaging. This is the team of neurosurgeons. You'll recognize this handsome gentleman right here in his home environment of the operating room. This is our team of physiatrists and anesthesiologists. These are the people who do more invasive treatments, but not quite surgery. We have a couple neurologists. You see that nerve testing machine that is that's sitting there. We'll talk about that shortly. We have a entire physical therapy department and a chiropractor, full complement of physician assistants to help us with our day-to-day operations. There's the address in case you missed it. So we'll talk about all the things involved in carpal tunnel syndrome. What is it? Why does it happen? Who gets it? And what can we do about it? So this is the carpal tunnel. Is this ligament right here across your hand. So if you look, it actually starts at about this line across the bottom of your hand and goes up for about an inch, maybe an inch and a half in certain people. And what makes it unusual as a pinched nerve is it's just a very broad ligament that pushes down, that full inch of nerve. This is, the picture on the left is what we call a cross section. If you cut your hand off this way and you look straight down it, you see the nerve runs, this is the carpal tunnel. The sides and the floor are the wrist bones that are there. And then those blue things are 8 tendons that go to the fingers, and then that one lonely nerve that sits there. That's why all the repetitive use disorders that cause inflammation of the tendons, there's nowhere for the nerve to go. That broad ligament that you see in the left picture, it makes up the roof of the carpal tunnel. And so there's really nowhere for the nerve to go. If there's some swelling within that tunnel, it just presses on the nerve, and then you get all the resultant symptoms. You'll also see in this picture on your left is those yellow branches go up and they control 3.5 of those fingers. On the 4th finger it only covers one side of it. So some doctors look to that a lot as a clue if it's carpal tunnel or if it's not. The carpal tunnel of love? I don't know, it's pretty weak, I think. So the title of the slide is Classic Symptoms because very often it's not classic. And if you look at the textbook, people say that you get numbness in 3.5 fingers, you'll get tingling in those 3.5 fingers, and you might get weakness of the hand. But that's not normally the case. People come in with sort of a variety of complaints and they may not have all of those things together. A common thing is maybe their hands aren't weak, but they have difficulty manipulating small objects or doing jars or doing buttons. The coffee cup is another one. I feel like I drop things all the time. I have no confidence. And the symptoms are usually worse in the morning or they wake you up at night. And people, they don't say anything. We have a name. It's called a flick sign. People will just shake their hands at you and say, well, it feels like this. But things can be atypical. People can have numbness in the small fingers over here. There's a reason for that. There's another nerve that runs next to the carpal tunnel that might be pushed on also. People can have numbness in all the fingers. People can have pain not just in the hand, but pain clear up the arm, even to the neck. There's cases where people have had carpal tunnel surgery and their neck pain goes away. That's not typical, but it is possible. Although carpal tunnel affects women about 3 times the rate of men, when men get it, it tends to be more frequently atypical than in women. Women are more likely to give you a more classic type, and men especially can be atypical. Risk factors, the picture of the woman typing there, and she's in extreme agony there, is not the typical thing. When you tell somebody that they have carpal tunnel, they will often say, but I don't type. And it's really never even been that strong of a risk factor. I put occupational exposure at the bottom, but even that is controversial. So women, 3 times more likely. People who are obese with a high BMI are more likely to get it. Pregnant women will often get it, and the reason is because you retain fluid when you're pregnant, and that fluid has nowhere to go, so it fills up that rigid tunnel there. Genetics plays a big role. The shape of those bones that make up the tunnel, really people with a smaller tunnel are more likely to get carpal tunnel. So it does run in a family. The shape of the wrist, the more square your wrist is, the more likely you are to get carpal tunnel. So basically the more narrow that tunnel is, the more likely you are to get it. And then there's other medical conditions that predispose people. The thyroid condition also causes fluid retention that can cause it. People with underlying nerve problems, and with people with inflammatory conditions within the wrist bones themselves, what's connective tissue diseases, can get it. And people with diabetes are more prone. Occupational exposures, anybody exposed to prolonged pressure over that area, repetitive use, or vibration is another one that will make people predisposed. And often people that come in are retired. They have done those things for years, and then they come in, they say, well, I stopped doing that, and why didn't it go away? The answer is the damage was done. The most important thing, I think, with carpal tunnel, there's 2 reasons people don't do well with carpal tunnel treatment. And number one is it was too severe. It's too far gone. By the time somebody comes in, there's really not much to be done. And the second reason that people don't do well is they really didn't have carpal tunnel to begin with. And then they go and they get the surgery and they say, well, I'm still having pain in my hand. So the diagnosis is a very important piece. First of all, carpal tunnel syndrome is a syndrome. Sorry, I'm blocking you guys out. And it's diagnosed by the doctor based on a discussion and based on an examination. And what we arrive at in the office that first time is really what we go with. Everything else is to support that diagnosis or to determine how severe or what stage you might be in. And then, very importantly, to exclude other things. I'm a firm believer that patients can have as many diseases as they would like. So you might have carpal tunnel and something else. So as long as we know what things you have going into the treatment, we know what to expect. Laboratory tests can be important to exclude some of those connective tissue diseases. Very often we'll diagnose people as a diabetic and they didn't even know. This can be the first presenting sign. The EMG and nerve conduction test, I think I have a slide after this. X-rays are useful if somebody has some arthritis, rheumatoid or osteoarthritis. Ultrasound is an emerging non-invasive diagnostic tool that can be very helpful, especially if somebody has an anatomic variant. Sometimes the nerve can be split, and MRI can be helpful in some unusual cases. There can be a mass within the wrist that is pressing on the nerve and not just the typical symptoms. The top picture is an ultrasound showing, again, that cross-section of the wrist. The nerve is highlighted up here, and one of the hallmarks is the nerve is flattened. It's basically being smushed, and it also swells and enlarges. You see this hourglass shape in the MRI on the bottom, and that's kind of a characteristic thing that Dr. O'Malley might find at surgery. Not everybody needs an ultrasound or an MRI. How many people have had an EMG and nerve conduction test? Wasn't that fun? It's a very direct way to measure the nerve directly and indirectly. In one part of the test, you put electrodes over a nerve, and then you stimulate the nerve upstream, and then you measure the impulse as it conducts. And if the nerve goes very slowly through the tunnel, you'll see some slowing. The EMG portion of the test is where we indirectly study the nerve by examining the electrical activity of the muscle itself. To do that, we use a small needle. It's a needle smaller than that you would get a flu shot with. And most people say, everybody usually does fine with it. Obviously, you're getting a needle stuck in your arm in a couple different places. The most important part of this test, what this test really does, this test has been around since about the 1950s, but some advances in the technology of putting it on a computer and the needle technology have really made it less uncomfortable. The test has a very bad reputation, but it shouldn't be that bad. There's a variety of people doing nerve tests, and personally, it doesn't matter to me where you get it done as long as you get the test done properly. There is EMG labs can be accredited by a national body, and our lab here in Hagerstown is the second. There's only 2 labs in the state of Maryland that are accredited, so you can go out to Bel Air to the other one. There's one in York, Pennsylvania, and there's ours, as long as you get the proper test. But the main reason to do that nerve test is to exclude all those other things. So people with numbness in the fingers, very often it could be a pinched nerve in the neck, a pinched nerve in the shoulder region, or what's called the brachial plexus. You've heard things called thoracic outlet syndrome, or the median nerve not at the wrist, but the median nerve somewhere else along the course can be entrapped. It's very uncommon, but it has to be checked. And then the ulnar nerve runs parallel to that median nerve. That can be compromised as well. And very often we'll see people have more than one problem. And this is what we're trying to prevent. About once, maybe twice a month, somebody comes in to the clinic and you can't even get a reading to determine that they have carpal tunnel because the nerve is completely obliterated. And the nerve controls a lot of the muscles on this portion of the hand, and you can see the wasting and scalloping in that thumb region there, and there's just absolutely no grip strength, and there's really no way to get this back. You can do some fancy nerve transfer after this, but you have to borrow that nerve from somewhere. You have to rob Peter to pay Paul to get some of that function back. So even as people approach the end stages, there's reason to treat to keep it from getting to this point. The treatment options, Betty Jo's going to talk to us a little bit about some of the physical therapy protocols, nerve and tendon stretches, and some workstation ergonomics. These pictures of the braces, everybody seems to be so happy in them, and I've worn one, and it's like you wake up in the morning and it's on the floor, or it's really hard. They make it look easy. A lot of things have been studied, things like diuretics, B6. It might be helpful. It's not that strong. Anti-inflammatories like Motrin, or the prescription ones, can be helpful, maybe early on. Carpal tunnel typically waxes and wanes. People get it, and they may get periods of remission and then periods where they feel worse. And during periods of flare-ups, the anti-inflammatories can be helpful. I don't think it changes the overall outcome. The conservative treatments are going to work, or it's not. The injections are very helpful at reducing pain, and they can also reduce some of the swelling on the nerve, but they're really not thought, they're really temporary. The biggest role that I use it for is more for diagnostic purposes. If somebody comes in and they have some relatively vague symptoms, or we do the nerve test and we find that they have more than one problem and we're not sure, somebody's response to a carpal tunnel injection can help predict their response to eventual surgery. So if they do well with the injection, it wears off, they'll probably do well with surgery.
Excuse me.
Yes?
What are those that are being injected?
Say again?
Being reviewers?
Oh, it's usually a steroid, an anti-inflammatory steroid. Cortisone would be the most generic that people know, but they're all derivatives or related to that. So anti-inflammatory type steroids and maybe some anesthetic. And then the outcomes, people who, people who go on to have surgery, we try to put people with the nerve test in a box of, very mild, moderate, up to very severe. But all of those groups show improvement with surgery. Anywhere, even people with severe findings, maybe about 25% of them will get complete remission of symptoms. A lot of people will get partial. People in sort of the middle ground, about 60% will get complete remission of symptoms after successful surgery. But all across the board, all severity levels, people do get better. And this is not how we do it anymore. I don't know. But you see there's a quite enlarged nerve that they're pulling out of this guy's wrist. This is supposed to scare you, I guess, into having something done. So remind me, if Dr. O'Malley doesn't cover the definition of minor surgery in his talk, remind me and I'll chime in.